I am Dr. Saqib Mansoor, and my today's topic of discussion with you is the anatomy of the knee joint. So, knee joint, this is a very sophisticated joint and a very complicated joint, and it is very superficial joint, and most of the part is subcutaneous, right? So, there are certain factors which make it unstable. So, we have to find the factors which make it stable. So there are factors stabilizing it. So that they are the, of course, muscles and the ligaments. We'll discuss in later. And then first of all, we'll discuss its articular surfaces. What are those, right? Which bones are contributing to its formation, the articular surfaces of them, and the type of the joint, right? And the ligaments and the muscles around it, the relation, some of it very important relation, then the movements, and then all the fibrous capsule and the menisci, the fibrocartilaginous structures present in between them, right? You see this is the joint over here, and the center, this is the patella, and from above comes the femur surrounded by these muscles, especially this is the quadriceps femoris, the three vasti, and one is the rectus femoris. And this is patella, this is the tibia, and this is very important, the ligamentum patelli, the ligament of these quadriceps femoris, right? So it attaches to the tibial tuberosity. This is the overall layout. So this is, the surface anatomy. I'm not going to, mention it over here. These are the vasti, and this is the patella, right? And this is the tibia part, the tibial tuberosity, like this. And here you move on to this picture, and like you see, this is the patella, which is, remember, the articular surfaces, three bones are contributing to formation of the this knee joint. Three bones contribute to its formation, and first of them is the femur from above, right? From below is the tibia, and the third is the patella, right? So I will show again the their precise articular surfaces contributing to the formation of the knee joint. Here it is the knee joint. It is itself, and the point to be noted that this is the other bone of the leg. One is a tibia, taking part in the formation of the our knee joint, and fibula does not take part in the formation of the knee joint. Fibula does not take part in the formation of the knee joint, right? So this is the tibia, femur, and the patella. And this is shown, and we'll come back to there. This is the X-ray, the radiograph, right? This is, this is the femur, tibia, and this is fibula, right? So I will talk about these condyles of the femur and the condyles of the tibia and the tibial plateau over here. So moving to the similarly from these slides, right? So the type of joint is basically it's a hinge type of the synovial joint that permits flexion and extension. These are the main movements, although the hinge movements occur in combination with gliding and rolling and with rotation around a vertical axis, right? So this is a general description of the type of the joint. So it's a synovial joint, of course, movements occurring here, and the hinge variety. So articular surfaces are large and their shapes are complicated and incongruent, right? The point is that the shapes are not, congruent. Congruent means they are incongruent, means that they are not fitted onto each other. They are not fitted exactly on each other. So not it's a lot of incongruence, right? So in different position of the movements, like in full flexion and in semi-flexion and the full extension, there are different parts of the condyles which are meeting the different parts of the relative condyles. We'll tell in the locking and non-locking of the knee joint. Very important aspect in the movements, locking and unlocking of the knee joint. So this is the articular surfaces from, contributing from the above. This is the lower end of the femur, right? So this is the lateral condyle. This is, you can recall the anatomy of the femur. As you can see even here, this is the medial condyle of the femur. This is the patellar surface, right? So these are the three parts of the bone contributing to the formation of the knee joint for parts of the this femur. As we come down, this is the lower bone, which is the tibia, told you already. So these are the tibial condyles, right? So they contribute to the formation of the knee joint from below to the this femur, right? This is the this is a medial tibial condyle, and this is a lateral tibial condyle, and in between the joint there is a fibro cartilaginous these menisci, lateral meniscus and medial meniscus. We will discuss them in our section with the ligaments and all these ligaments, rest of them as well. This is patella, right? This is from posterior view, and this is various parts of the patella. You can find them in the relevant study of the patella, right? This patella also takes part in the formation of the knee joint. These are the three bones, and you will see again. This is coming back. This is anterior view of the knee joint. This is femur and above, and this is the patellar surface, right? And these are the condyles, right? This is the tibia, and these are the condyles of the tibia, and these are the menisci. These are the ligaments. I will talk about each and every ligament separately in detail. So articulations you can study like the femorotibial articulations, medial and lateral, and the intermediate femoropatellar articulation. So what are you labeled over here, right? So this articulation between the condyle, medial condyle. This is medial condyle of the femur. This is the medial condyle of the tibia, and this articulation is known as the medial femorotibial articulation, right? And here this is lateral condyle of the femur above, and this is below the lateral condyle of the tibia, and here we find the lateral femorotibial articulations. These are the two femorotibial articulations, and this is the intermediate. This is the patellar articulation, and this is, you can see the patella, right? This is the patella, right? So this is and this is this is the joint cavity always, where the menisci are also present. So this is a point. Here you can see also in this picture that this is these are the condyles, these are the condyles, this is femoral condyles, these are the tibial condyles, and this is the patella. So this is various parts of the joint. I've told you already. So I told you astonishingly, if somebody asks you whether the knee joint is a strong joint or a weak joint, some people say, the students especially learners of anatomy, that's a weak joint, but no, it's a strong joint. And the knee joint mechanically is not a strong joint, it's a weak joint, because the articular surfaces, I told you, are incongruent. They are not exactly opposed to each other. So knee joint is a weak joint mechanically. So we have to look for the stability factors. The stability comes from these factors, right? They are, you can talk about these, the stabilizing factors of the knee joint, which does not allow it to dislocate or else. So this is the strength and actions of the muscles and the tendons that surround the joint. A lot of the muscles and the tendons surround the ligaments joining the femur and the tibia. So lot of ligaments we'll talk about in detail very soon. Muscles are the most important stabilizing factors, right? Beyond the ligaments, these are the most important stabilizing factors anteriorly, posteriorly, medially, and laterally. And the anterior muscles is most important. This is the quadriceps femoris, made up of the three vasti: vastus medialis, vastus lateralis, and vastus intermedius, along with the rectus femoris. We showed the picture already. And posteriorly is the gastrocnemius and hamstrings. These are the ham muscles, the hamstrings, right? So this is the posterior compartment of the thigh. And as moving to the lateral aspects, this is the biceps femoris. This is also the posterior sport and the lateral sport, posterolateral sport. Gastrocnemius, I've already told you, it's lateral head sports, laterally. And basically, gastrocnemius, I already told you, is a posterior sport. So this is the point. And the iliotibial tract, very important, the lateral support, and it also stabilizes a lot. You recall, and if you haven't studied, you can go there, that there is the tubercle on the tibia, which is known as the Gerdy's tubercle. This Gerdy's tubercle is where the iliotibial is attached or inserted, so it contributes to the lateral support. And this is the popliteus, which is located posterolaterally beneath the fibular collateral ligament. So this is popliteus is the lateral support. So then the medial support, semimembranosus, and this is a posteromedial support. Then the medial head of the gastrocnemius, though mostly a posterior support. This is a pes and serinus. What is that? Pes and serinus. So three muscles that are located one after the other on the medial aspect of the tibia, the medial tibial condyle. These are the sartorius, gracilis, and semitendinosus, SGS. You can make a mnemonic SGS, that is the sartorius, gracilis, and semitendinosus. And collectively, they are these three muscles are known as the gyropes. And if you go to the anatomy on the innominate bone or the hip bone, these are the three muscles that are attached to all three parts of the hip bone, the ilium, ischium, and the pubis, the gyropes. So the most important muscle in stabilizing the knee joint is, of course, the quadriceps femoris. I told you already, the most pivotal part in the stability of the joint, particularly in the inferior fibers of the vastus medialis and lateralis. Keep in mind that the patella, due to the disposition of the knee joint, has a tendency to displace laterally. So it is prevented by the disposition of these muscles, vasti, especially this vastus lateralis, and here these two muscles. And after a ligament is strained and the quadriceps is working normally, the function of the knee joint remains quite well, right? So it's a very important point in the rehabilitation. If a ligament is strained or damaged, the quadriceps muscle is intact, its nerve supply intact, its function is perfect, its size is perfect, the function of the knee joint remains quite well. So this is giant capsule basically, and you can see the various part of the what I've told you already. This is the muscles, right? This is a vastus lateralis. See, this is a vastus lateralis. This is a vastus medialis, right? And from this is the femur, and this is from above comes this over rectus femoris, right? And these then vastus intermedius also present over here, is labeled over here, right? So these four muscles, they form a common tendon, which is of course the patellar ligament or the ligamentum patelli. So this is inserted onto this tibial tuberosity. This is the main support of the knee joint. So this is the point, and this is posterior. This was the anterior aspect, and this is from posterior. This is all I've already told you. These are the various muscles with the hamstrings, and then the medial and the lateral side. This is the medial side, and here you identify your pes and serinus. I tell you in the end with a separate picture of these three muscles: semitendinosus, gracilis, and semimembranosus. So this is the point. So the most stable position of the knee joint is while one is standing erect and knee joint is extended. The articular surfaces attain maximum congruence in this position. Collateral and cruciate ligaments, we mentioned soon, they are the primary ligaments of the joint which get taut, right? So collateral ligaments, the two sides, the medial collateral ligament and the lateral collateral ligament. And the splinting effect is provided by many tendons that surround the joint. So this is the stability. So the most stable position is someone is standing erect in the anatomical position, you say, and the knee joint are in extended position, straight. So the relations, some relations very important. The joint I told you is subcutaneous, and anteriorly, there is quadriceps, patella, the patellar ligament, the biceps tendon is laterally, and the semimembranosus and semitendinosus medially. And you can see from this picture again coming back, right? This is the anterior relation, this is the medial one, and this is the lateral, like we see biceps femoris. So joint capsule, so very important topic. The joint capsule, which various two layers, fibrous and the synovial. So external layer is the fibrous layer of the joint capsule of the knee. So, and an internal is the synovial membrane. So it aligns all internal surfaces of the articular cavity, which is not covered with hyaline or the articular cartilage. So let's see the joint capsule. This is the internal aspect of the joint capsule. You see here, this is the, this is the, the tibial plateau, upper superior aspect of the tibia, and this is shown from above, tibial plateau, and this is the attachment. So you can further enlarge this picture for you, and for a better view of the this picture. So let's see this. Yes, here you could focus that. So this is this attachment, this in red, right? So this in red is our inner attachment of this synovial membrane, synovial part of this fibrous capsule, and this outside black line is the, this is our the fibrous layer. So make it a point. So this is the fibrous layer. This is the labeled over here. This is the fibrous layer. This is I'm tracing outside this dotted line outside. This is the fibrous layer of the joint capsule. And from this reddish line, red line is a synovial membrane. This is sounding like this, and we can make a general discussion from here. You see, this is a fibrous layer. As it comes this anteriorly, there's a gap in the fibrous capsule here, fibrous layer of the joint capsule, from which the popliteus tendon passes. This is the gap, right? And this is, and as we move on here this way, so this, this attaches to the this part of the bone, and then we move on to the this is synovial, membrane. This is in red, so it is surrounding all the way through. Like these are the articular surfaces of the lateral condyle covered by the hyaline cartilage. It does not, of course, line the synovial membrane. These it's surrounding all around, right? This like this, inner to this fibrous layer. This is enclosing this like this, and here is the site of attachment of the anterior cruciate ligament, and from here it forms that it's reflected on each side of that attachment, and this forms the infrapatellar synovial fold. So this is the infrapatellar synovial fold. I will talk about these things in detail in the next sections. And you also look alar folds right over here. This is the synovial membrane, and this reflects interiorly, this beyond this anterior intercondylar area, and this like forms the alar folds. And there is another thing from this fibrous layer of the capsule, that is the lateral patellar retinaculum and the medial patellar retinaculum. We'll talk about the retinacula in detail very soon in the next sections. So we can look at the below picture as well for some of the things beforehand as we move on. And this is the synovial membrane, right? This, right? This is the synovial membrane. This, you see the hand moving, the cursor. So this is the synovial membrane all around, right? The joint. This here in the midline forms a infrapatellar synovial fold. I will talk about it later. This is the articular cartilage, right? So this is a synovial fold, and this is the fibrous layer outside. This is the fibrous layer, and this is the synovial membrane. As you could see, identified. This is the fibrous layer of the joint, and this is inside is the synovial membrane. As you could see various pictures over here. From here, this is the fibrous layer, and inside is the synovial membrane. So fibrous layer in most part is thin and rather incomplete. I told you already. And sometimes it has thickened parts which forms the intrinsic ligaments. The fibrous layer attaches to the femur superiorly, just proximal to the articular margin of the condyles, proximal to. And the posteriorly, the fibrous layer encloses the condyles and the intercondylar fossa. The fibrous layer has a gap or opening posterior to the lateral condyle of tibia, which permits the tendon of the popliteus to pass out of the joint capsule to attach to the tibia. This already told you there's a gap which for the tendon of the popliteus, one point, and anterior this proximal attachment to the articular margins of the condyles. This is superiorly and anteriorly, and this is the posterior attachment is encloses the intercondylar fossa. Here you could see, right? This is the anterior attachment of the capsule, and this is posterior. There is a gap. This is the gap in the capsule of the popliteus tendon. This is the point. I told you already. This is described over here. I told you already. And this is the joint capsule again. You can see various. These diagrams will come again and again in various descriptions, and I will tell you the relevant points in that. Here you could also identify this iliotibial tract to attach to the this tibia, Gerdy's tubercle of tibia. This is again this you say joint capsule, and I've already described you description, right? This is the point. So inferiorly, the fibrous layer is attached to the margin of the superior articular surface of the tibia, except where the tendon of the popliteus crosses the bone. And anteriorly, fibrous layer is replaced by the quadriceps tendon, patella, and the patellar ligament, right? Anteriorly. So that means the fibrous layer is continuous with the medial and lateral margins of these structures, and there exists no separate fibrous layer in the area of these structures. Which is these structures? Go back anteriorly. Yes, these are quadriceps femoris, the tendon of the patellar tendon, and this is the patella. The joint capsule separately does not exist. It merges with these structures. So, synovial membrane just lines all surfaces that line the articular cavity not covered by articular cartilage. So it is attached to the side of the articular cartilage that covers femoral and tibial condyles, the posterior surface of the patella, and the sides of the menisci. The synovial membrane lines the internal surface of the fibrous layer medially and laterally, but in center it becomes separated from the fibrous layer. You already will show you again, right? This is some points to be noted. So quickly going through that again, we go back to this picture, right? This is in the, it says in the center, right? This is, fibrous layer. This is the synovial membrane. They are going side by side here, but in the midline, this synovial membrane gets separated from this fibrous capsule. Here it goes, it forms this infrapatellar synovial fold on the both sides. This is I was trying to say and mention in the text. This is the point. So now the synovial membrane is posteriorly reflected onto the anterior part into the intercondylar region, covering the cruciate ligaments and the infrapatellar fat pads so that they are excluded from the articular cavity. And this creates a median infrapatellar synovial fold. I've shown you already. It's a vertical fold of synovial membrane that reaches the posterior aspect of the patella, occupying all except the most anterior part of the intercondylar region. In this way, the articular cavity is subdivided into left and right femorotibial articular cavities. So this is the formation of the infrapatellar synovial fold, which divides the articular cavity into left and right this articular cavities. You can see from this picture again. This is the infrapatellar synovial fold, and I am going to enlarge this for you again for a better description. So want to clear everything about knee joint. So this is the infrapatellar synovial fold, right? So this is how it is formed. I've told you already 2 times from this synovial membrane, and here in the midline, this is the reflection, and these 2 cavities are right lateral and medial side form joint cavity by this infrapatellar synovial fold from here, right? This is the reflection in the midline. And the lateral and medial alar folds, it showed you already, the alar folds, then again, and these are filled with fat, cover the inner surface of the fat pads that occupy the space on each side of the patellar ligament internal to the fibrous layer of joint capsule. Here you could see alar folds. This is the fat, and these are the alar folds. This is a picture in another format. This is the alar folds. So this is the point of the alar folds. So then coming to the superior to the patella, cavity of the knee joint extends deep to the vastus intermedius and form the large suprapatellar bursa. Yes, so very, very important suprapatellar bursa. And I'll talk about all the bursae at the end. It is synovial membrane of the joint capsule is continuous with the synovial lining of this bursa. So it can extend very up, even up to the midline of the thigh or even above that. Generally, it is 5 centimeter long, this suprapatellar bursa. You can see over here, right? This is, then again, from here, you can enlarge the picture. Yes, here I go. This you see it is labeled over here. This is the suprapatellar bursa. Yes, here. I've told you already. Below this vastus intermedius, extension of the synovial membrane. So this is the bursa. Then the important small muscle articularis genu, muscle slips that are deep to the vastus intermedius constitutes the articular muscle of the knee or the articularis genu, which is attached to the synovial membrane, and it retracts the bursa during extension of the knee. It retracts this bursa during extension of the knee. It prevents its nipping. So this is the articularis genu. You can see over here. This is, I can enlarge for you again immediately. So you see here, yes, this is this muscle, yes, this slip, these muscle slips attached to the joint capsule. This is the articularis genu. Articularis genu is the articular muscle of the knee, which prevents, attached to the synovial membrane and retracts the bursa during extension and prevents its damage in the nipping. So the ligaments are divided into extracapsular and intracapsular. Very important. Some are inside the capsule and some are outside the capsule. There is also another structure, completeness, which is described in relation to this capsule. So the external ligaments of the extracapsular ones are the patellar ligament, fibular collateral ligament, tibial collateral ligament, oblique popliteal ligament, and the arcuate popliteal ligament. So this is the point. This you see already. This is the were mainly this patellar ligament, ligamentum patelli, and on the sides this is the tibial collateral ligament. This medial side, this is the tibial collateral ligament, and on this side, this is the fibular collateral ligament. This mainly this picture shows these ligaments, and over here you see this oblique popliteal ligament. We're not talking about over this. This is oblique popliteal ligament, and then also we have to identify this arcuate popliteal ligament. So these are the 5 ligaments identified over here, right? So 1, 2, 3, and this is the arcuate popliteal ligament and the oblique popliteal ligament, right? So identified. So then this patellar ligament, I told you already, this is distal part of the quadriceps femoris tendon, thick, strong fibrous band passing from the apex and joining margin of the patella and attached to the tibial tuberosity. On the lateral side, this receives the lateral and medial patellar reticula, aponeurotic expansion of the vastus lateralis and medialis, and the deep fascia covering them. I told you already these reticula, which strengthen the joint, lateral and medial reticula. I showed you again. So this is the point. This is again the picture. These ligaments, and as we come on, and then we move again. So this is the retinacular fluid, right? They constitute the joint capsule of the knee joint on each side of the patella and perform an important role in maintaining the alignment of the patella in relation to the patellar articular surface of the femur. I told you the patella has a tendency to go out of its alignment laterally. So this is the you can see this is the medial patellar retinaculum, and this is the lateral patellar retinaculum. I've talked about you their formation from the vastae, respective vastae, vastus muscles. I got this one Q angle. What is that? And let's discuss. I told you this mentioned already. This is the Q angle. This is responsible for the small Q angle. This, I tell you, these two lines. This is responsible for the lateral displacement of the patellar. It is formed between two lines. So let's again enlarge it for a better view. So you can, there are two lines formed in relation to this patella, femur, and hip bone. One comes, this is the anterior superior iliac spine, and coming down, it comes to the midpoint of the patella. This is one line, right? And the second line, line of the gravity. This here it comes pull of the over the muscles, and line of the gravity, and here it also comes to the middle of the patella, and this is also going through the tibial tuberosity. You can describe it that way. It is a line drawn from the middle of the patella to the tibial tuberosity. Some people it's also say tibial axis. That line passes through the tibia center. So these are the two lines, and they form a small angle Q angle. So this makes the patella to displace laterally. So this is the point of this Q angle. It is 13 to 17 degree relative to the gender of the person. Then the collateral ligaments, this medial and lateral, they take part in the stability. Well, when one is standing position, as flexion proceeds, they become slack and loose. So they are taut in the position of extension, and permit a limit and serving as check ligaments for the rotation at the knee. They are the check ligaments to prevent rotation. These are the pictures of the collateral ligaments of the knee. So you see, this is the lateral view, and the lateral side is the our lateral or the fibular collateral ligament. Here you could see this is a fibular collateral ligament. Of course, this is a fibular will be attached to the fibula. Though fibula does not take part in the formation of the knee joint, but that this ligament, of course, provides. It's on the lateral side of the knee joint. It provides support there. So, and of course, this is attached to the femur. This is the medial view, and from here, so we'll first of all enlarge this picture because the labeling is a bit small. Yes, here you could see this is the tibial collateral ligament. It's the two parts. This is the tibial collateral ligament. Here you see this is the tibial collateral ligament. So these are the two collateral ligaments: medial collateral ligament, yes, also known as the tibial collateral ligament, and the fibular collateral ligament, also known as the lateral collateral ligament. Lateral means situated on the sides. So what talk about the fibular collateral ligament? Strong, cord-like extracapsular ligament extends inferiorly from the lateral femoral epicondyle to the lateral surface of the head of the fibula. The tendon of the popliteal passes deep to this fibular collateral ligament and separates it from the lateral meniscus. This noted, this lateral meniscus is not attached to this ligament, fibular collateral ligament. Fibular collateral ligament divides, it splits this biceps femoris tendon into two parts. It goes through and through the biceps tendon, fibular collateral ligament. You can see this picture. Here you could see this is the fibular collateral ligament, right? And let me make it a bit larger for you. And yes, here for the better, this is the fibular collateral ligament, right? And this is the biceps femoris, this, right? So this, pierces this biceps tendon, this the fibular collateral ligament. You could see here, yes? And this is a popliteus, tendon of the popliteus passes beneath it. And these are the attachments that you can also see in an enlarged view. Again, where it is attached, this fibular collateral ligament. And this is femur, lower end. This is fibular collateral ligament attached to the epicondyle, lateral epicondyle of the femur. And then Similarly, below, this is the attachment of the fibular collateral ligament onto the upper aspect of the fibula. Then the medial or the tibial collateral ligament, flat, strong capsular band that extends from the medial femoral epicondyle to the medial condyle and the superior part of the medial surface of the tibia. So at the middle point, the deep fibers of the tibial collateral ligament are attached firmly to the medial meniscus. It is noted that the medial meniscus is attached firmly to the tibial collateral ligament, whereas in contrast, the tibial and the femoral, the lateral collateral ligament is not attached to the lateral meniscus. So this comes into a very important clinical aspect, which is the unhappy triad. So that is why it involves a damage of the on the medial side. This is a tibial collateral ligament and the medial meniscus and the anterior cruciate ligament. There's unhappy triad. We'll describe in a separate lecture because it will go into very long this lecture as well. And this is a tibial collateral ligament, right? You see the attachment of shown you already, and I will make the picture already. And again, this enlarging. Yes, you see, this is the tibial collateral ligament coming from the epicondyle of the medial epicondyle of the femur, and it has these two bands and attached to the condyle of the tibia, attached to the condyle of the tibia and the medial surface of the tibia respectively. This is the tibial collateral ligament. Its parts, you see here, its two parts. And then in this picture, the attachments, this is the tibial collateral ligament, right? This is the epicondyle, medial epicondyle of the femur. This is femur, and this is tibia, and this is the tibial collateral ligament, right? Attached to this part of the tibia upper, and this is the tibial collateral ligament attached to the surface, this medial surface of the tibia. And this is a separate view. It's a beautiful picture, I tell you. You could see that this is our tibial collateral ligament. Okay, I told you attachment, just have a look at that. This is isolated, beautiful picture, right? This is the tibial collateral ligament. It's extended from this femur epicondyle to that part of the medial surface of the tibia. And this is the other aspect of this. This is, in extension, this is a 90-degree flexion, and here it is laxed. This is again this tibial collateral ligament, and this is that relaxed position. This is flexion, and this is extension. This is the quadriceps tendon. Yes. So collateral ligament of the tibial is weaker than the fibular collateral ligament. It is more vulnerable to injury. So as a result, the tibial collateral ligament and the meniscus, medial meniscus, which is attached to it, they are commonly torn during contact sports such as football. So, and the anterior cruciate ligament is also associated with that. So they make a very important clinical aspect of the disease. This is the unhappy triad. Extracapsular ligaments, oblique popliteal ligament expansion of the semimembranosus. If you go to the attachment of the semimembranosus, it's a distal attachment or the insertion. It is the forms the oblique popliteal ligament, one of its attachment. It strengthens the giant capsule posteriorly and covers the intercondylar fossa of the ligament. Oblique popliteal ligament or takes its origin posterior to the medial tibial condyle and passes superolaterally toward the lateral condyle of the femur and is attached to the central part of the posterior aspect of the joint capsule. So this is the point. Here you could see that this is the oblique popliteal ligament and this is the semimembranosus. You see, this muscle is the semimembranosus. So, and this gives origin to the over this oblique popliteal ligament, right? This described already. Then is the arcuate popliteal ligament also contributes to the stability, and its origin from the posterior aspect of the head of the fibula, passes supromedially over the tendon of the popliteal and spans over the posterior aspect of the knee joint. So this is the arcuate popliteal ligament. You could see this is the arcuate popliteal ligament. This. So development of this ligament considered to be an inverse proportion to the presence and size of the fibula. What is fibula? It's a sesamoid bone present in the tendon of the lateral head of the gastrocnemius, right? So both structures are attributed to take part in the stability. And now coming to, these were the extracapsular ligament. I just told you 5 ligaments, and then to the intracapsular ligaments. These are just the cruciate ligaments, anterior and posterior, and meniscus, lateral and medial meniscus. And the tendon of the popliteus, it's not a ligament, tendon of the popliteus, but it's an intra-articular structure. I told you gap for it and how it is present and related to the bones and the joint capsule and the joint cavity. And the cruciate ligaments, they lie within the joint capsule but outside the synovial cavity, within the capsule. And they are cruciate because they are situated in the center of the knee joint and they cross each other, they form a crisscross, and that like the letter X, this X. It shows you the picture. When tibia rotates medially on femur, the cruciate ligaments wind around each other, restricting the amount of medial rotation up to about 10 degrees. So in certain locking, unlocking, I will tell you again that tibia rotates medially on the femur, and this ligament, cruciate, and both ligaments, they restrict the amount of medial rotation up to only 10 degrees. And you see, this is a picture of the cruciate ligaments. This is the anterior cruciate ligament, and this is the posterior cruciate ligament. Anterior and posterior, they form a letter X, like this, crisscross manner. And this, the knee is flexed over here. This is, of course, internal view of the knee, and the knee is flexed. It's a beautiful picture, right? You see, this is the cruciate ligament with this beautiful cross, right? This is cruciate ligament, anterior and posterior. This is the posterior, and this is the anterior cruciate ligament. And this is again from the back view. This is anterior, this is posterior view. This is anterior cruciate ligament, and this is the posterior cruciate ligament, right? This is the thing. You can also see beforehand these menisci. I'll tell you, show you again. And again, you see this is the this cruciate ligament, which is what I want to highlight, posterior cruciate ligament. So during lateral rotation, the cruciate ligament becomes unwound. So when the joint is flexed about 90 degrees, nearly 60 degrees of lateral rotation is possible to bring about. So if they are maintain contact with the tibial and femoral articular surfaces when flexion of the joint takes place. The cruciate ligaments crisscross and provides a pivot for the rotative movements at the knee. As cruciate ligaments are placed obliquely, in every position, one cruciate ligament or parts of one or both of the ligaments is definitely taut. Here you could see the cruciate ligament from this view as well. This is posterior cruciate ligament, and this is anterior cruciate ligament. And again, the description of this anterior one. This is the weaker of the two, and takes origin from the anterior intercondylar area. I will show you, just posterior to the attachment of the medial meniscus, extends laterally, superiorly, and posteriorly to get attached to the posterior part of the medial side of the lateral femoral condyle. Blood supply is very poor. This ligament, anterior cruciate. There you could see beautiful picture, superior aspect of the tibia, tibial plateau, and was talking about the attachment of the anterior cruciate ligament. Here you could see, this is the attachment of the anterior cruciate ligament on this side, right? So then we have to see this role. What is the anterior cruciate ligament role? It limits posterior rolling of the condyles, femoral condyles, on the tibial plateau during flexion of the joint. So it converts into the spin. It averts or avoids posterior displacement of the femur on the tibia. So we'll discuss in clinicals anterior drawer sign and the posterior drawer sign. to depict their role when they're damaged, the cruciate ligaments. So it inhibits hyperextension of the joint. At 90-degree flexion of the joint, the tibia cannot be pulled anteriorly because it's retained by the anterior cruciate ligament. These are the drawer signs. So this is the stronger posterior one. It originates from the posterior intercondylar area. It passes anterosuperiorly on the medial side of the anterior cruciate ligament and is attached to the interior part of the lateral surface of the medial femoral condyle. You could see the picture. This is the attachment of the posterior cruciate ligament. This is what I wanted to highlight. And this is of course attachments on the tibia. I told you there then how inserted into the femur. So this is the posterior aspect again, right? So you could see this is the posterior cruciate ligament, and also see this popliteus tendon. This is knee flexed again. This is the posterior cruciate ligament. This is anterior cruciate ligament. And posterior ones limits anterior rolling of the femur on the tibial plateau as extension occurs, thus converts it to spin. It also avoids anterior displacement of the femur on the tibia or posterior displacement of the tibia on the femur and prevents hyperflexion of the joint. In the weight bearing flexed knee, this ligament is the main factor responsible for stability of the femur. For example, during walking the downhill. So, right, this walking downhill or walking downstairs, this is a very important role of the posterior cruciate ligament. So these are the menisci, very, very important fibrocartilaginous plates, crescent shaped, lie on the articular surface of the tibia, tibial plateau, and they deepen the surface, perform a role in shock absorption, and involved in lubrication of the joint and have a proprioceptive function. So they are thicker on their outer margin and thinner on the attached edges in the interior of the joint. Transverse section, they are wedge shaped, attached at the ends to the intercondylar area of the tibia. Their external margins attached to the joint capsule of the knee. You could see their attachments, right? And you see this is the anterior aspect of the tibia. As you come on to this is the medial meniscus, right? And this is anterior attachment of the medial meniscus. This is the posterior attachment of the medial meniscus. This is also known as the anterior horn, and this is the posterior horn of the posterior end. So this is the attachment of medial meniscus, and this is the lateral meniscus, right? So this is the anterior horn of the lateral meniscus. This is posterior horn of the lateral meniscus attached on this intercondylar area. You know already these are the condyles, and between them is the intercondylar area, the tibia, tibial plateau, upper part of the upper surface of the tibia. This is the posterior surface, and here you could see this is the medial meniscus, and here is the lateral meniscus going like this. This is I already told you. Even first we showed the cruciate ligament, and here we have to show menisci. This is the lateral meniscus. This is the medial meniscus, plants with the synovial membrane on both sides. This is the coronary ligaments. What are they? Parts of the joint capsule that extend between the margins of the menisci and most of the periphery of the tibial condyles. Right? So a small fibrous band is a transverse ligament of the knee. Transverse ligament. It joins anterior edges of the menisci and crosses the anterior intercondylar area, and it tethers the menisci to each other during these movements. Very important role of the transverse ligament of the knee, because the meniscal tear and the meniscal injury is very important. We'll discuss later, next lecture. So this is again, you see, this is the menisci, right? And this is shown. This is the medial meniscus, and here you could see I wanted to show this is the coronary ligament. This is the coronary ligament attached to this medial meniscus. This is the point. And over this is the coronary ligament. Here it's attached to the this other meniscus. This is lateral meniscus. This is the coronary ligaments on each side. So this is the point of these menisci, and Then again, this picture as well, this is the anterior cruciate ligament. And this is usually told you the shape. This is the lateral meniscus and this is the medial meniscus. This is the point I wanted to show you here, right? So this is the coronary ligament here, coronary ligament. This also identifies tendon of popliteus, intracapsular. Then again, this menisci, this beautiful picture, medial meniscus. I'll describe the shapes. This is the lateral meniscus. Medial one, C-shaped. See again, this is the medial is almost a C-shaped. It's broader posteriorly than anteriorly, right? This is the anterior, this is broader, and this is posterior. I forgot, I think, to spot transverse ligament. You could see this. This is the transverse ligament, and this attaches to the menisci, ends of the menisci. So its anterior horn of the medial meniscus is attached to the anterior intercondylar area. I told you, and anterior to the attachment of the anterior cruciate ligament. I've told you a posterior horn is also attached there to posterior intercondylar area, anterior to the attachment of the posterior cruciate ligament. This is, you can see you again this over here. These are the meniscal attachments, lateral and medial. So it is firmly attached to the deep surface of the tibial collateral ligament. Again, very important point, the medial meniscus is attached firmly to the tibial collateral ligament deep surface. Because of its extensive attachments laterally to the tibial intercondylar area, medially to the tibial collateral ligament, the medial meniscus is less mobile on the tibial plateau as compared to the lateral meniscus, which is very mobile. So this is a picture again, right? So showing the menisci, right over here. These are the menisci. Lateral one, lateral meniscus is circular in shape, is smaller in size and more freely movable. You could see lateral meniscus, this is circular. This is C-shape or oval. Some people, this is the, you could say circular. Then the tendon of popliteal has two parts at its proximal end. One is attached to the lateral intercondylar lateral epicondyle of the femur and passes between the lateral meniscus and the inferior part of the lateral epicondylar surface of the femur on the medial side of the tendon and the fibular collateral ligament that overlies its lateral aspect. This is tendon of the popliteus. In the second part, lying medial to the popliteus tendon is attached to the posterior limb of the lateral meniscus. So this is the two parts of the tendon of the popliteus. One part is attached to the lateral epicondyle of the femur, and the second part, which lies to the first, medial to the first part, it is attached to the posterior limb of the lateral meniscus. Those two attachments, two parts of the popliteus. Posterior meniscofemoral ligament, so last ligament, the strong tendinous slip joins lateral meniscus to the posterior cruciate ligament at the medial femoral condyle. So, so let's identify it over here. This is, these are the various, structures, and this is the popliteus tendon. First of all, yes, you can see this. This is the popliteus muscle, and this is the tendon. This is the popliteus. And as we move on, again, there is shown the popliteus tendon in this picture, and you can identify that this is a knee joint picture, and this is patellar ligament is avulsed, bring broad tone lower, and here you see this is the lateral aspect, and here on the lateral aspect, this is the tendon of popliteus tissue. This is the tendon of popliteus lateral to this in this knee joint. And I want to show this posterior meniscofemoral ligament. Where this is the posterior meniscofemoral ligament. I told you description. Yes, here you can see. Yes, this is the posterior meniscofemoral ligament attached to the menisci and the femur. Movements, the flexion and extension, the main movements, and some rotation relatively also occurs. And for that, you got to know the pictures as well, and the muscles producing the movements, and some very important factors. So quickly going through that very quickly. So these are the knee joint movement. This is a transverse plane and you see this is the longitudinal axis, where this is the lateral rotation or the external rotation, and this is the medial rotation. So longitudinal axis passing through tibia makes a rotation, and this is the main movements, which is the flexion and extension and the main movements. This is, you know, extension, some of, and this is flexion, right? As this angle is reduced, this produces flexion, and this is around a, you know, transverse axis here, and this picture is in the sagittal plane. This is a transverse axis, makes possible this movement, flexion and extension, and this is our this other transverse plane makes the these our longitudinal axis. Every rotation is you know, around a longitudinal axis of the bone. Here is another simplified picture. This is extension, that this angle is 90 degrees, the femur and the tibia, and then this angle is reduced, and this produces flexion, right? And this is rotation. I showed you already. You can see, right? This is the lateral view, and here in this view, this is the medial rotation of the leg, where the knee joint flexed 90 degree, and this is the lateral rotation of the leg, knee joint flexed 90 degree. So very important, very important, locking and unlocking. What is that? Well, the foot is on the ground and the knee is fully extended. Knee passively locks because the medial rotation of the femoral condyle on the tibial plateau. This is a screw home mechanism. And this position makes the lower limb a solid column and more adapted for weight bearing. When the knee is locked, the thigh and the leg muscles can relax briefly without making the knee joint too unstable, right? This locking is provided. Why? Because the patient has, the person has to sit for a longer period of time. Many of, occasionally, some people are standing for the whole day, and some we doctors are, you know, have subjected to many hours, many days continuously, right? So this is a locking. It's very helpful when we are standing, like surgeons have to stand many hours, long hours. It's locking helps medial rotation of the femoral condyles on the tibial plateau, and all the ligaments in the muscle are in a relaxed position, so less energy is spent. And this is, and to unlock, what happens, the popliteus, this is the key to the, this one can ask, what is the key of unlock muscle of the lock knee joint? This is the popliteus muscle. It contracts, it rotates the femur laterally about 5 degrees on the tibial plateau, so that flexion of the knee can occur. Like this locking occurs in the last stages, 10 degree, so to say, of the knee joint. This movement of the, you know, when the foot is on the ground, so this foot will rotate, medial rotation of the femoral condyle. This makes the congruence different. Movements of the menisci. What is this? Due to the cruciate ligament, the rolling movement of the condyles during flexion and extension is limited, and still some rolling does occur, and the point of contact between the femur and the tibia moves posteriorly with flexion and returns anteriorly with extension. What happens during rotation? One femoral condyle moves anteriorly on the corresponding tibial condyle, and the other condyle moves posteriorly, thus rotating about the cruciate ligaments. Menisci must be able to migrate on the tibial plateau as the points of contact between femur and tibia alter. So let's few words about the blood supply of the knee joint. There's a genicular anastomosis, right? It's between femoral, popliteal, anterior and posterior recline branches of the anterior tibial recline and the circumflex fibular arteries. The medial genicular branches of the popliteal artery piece the fibrous layer of the joint capsule and responsible for the blood supply to the cruciate ligaments, synovial membrane, and peripheral margins of the menisci. I have to talk about the muscle producing movements we'll do after the blood supply. You could see the genicular anastomosis. These are the arteries I mentioned. Like this is important popliteal artery, and the superior lateral genicular artery, inferior lateral genicular artery, and here is the superficial medial genicular artery, middle genicular artery, inferior medial genicular artery. Right? This is from the genicular artery. I've told you all these are the 10 vessels. From above also the femoral, and from below the anterior and posterior recline branches, right? This is taking part in the formation of this. This is the genicular anastomosis. Genicular means anything around knee joint, knee. So this is the arterial supply, right? This is the femoral artery coming from above, giving the branches, right? And the femoral artery at this point in the popliteal fossa becomes popliteal artery, and has these 5 branches. I told you already in this picture, you can see again. And then this branch is posterior tibial, and this was the posterior view, and the posterior view, and this is the anterior view. And here this is the femoral artery, and this various branches over here, and from here this is the anterior tibial. And you see, I wanted to show this is the anterior tibial recurrent, right? They giving also and taking part in this genicular anastomosis, right? And this was the point. And very quickly, this is the arterial supply of the menisci, right? You see, these are the various arteries supplying that over here, and here. This is the middle genicular artery, it's a posterior branch, and here is the middle genicular artery, anterior branch, genicular artery, middle, and this anterior and posterior branches. And also here going to supply to the menisci, the inferior lateral genicular artery and inferior medial genicular artery, right? So this is blood supply of the. And before going to the innervation, I tell you the movements. What are the muscles producing movements? So extension, you already know how many degrees are possible. Normally extend from 0. This is a straight alignment of axis of tibia and femur. So extension possible is of course 0 degree, and the flexion possible is 120 degree. This is 0 degree, of course. There can't be any hyper extension. And from this point onwards, this is the flexion, and its degree is when the hip is extended, it is 120 degree, and when the hip is flexed, it is 140 degree. And if we do passive movement with hands, that is possible is the 160 degrees. So this is the point. And the medial rotation is 10 degree. I told you already, with knee flexed, and 5 degree with knee extended. So lateral rotation is possible up to 30 degree. This is the 5 degree, or to 5 to 10 degree. 10 degree you can say. This is the 30 degree lateral rotation. Extend. But the muscles producing, you already know from the function of the muscles that extension is produced by quadriceps femoris primarily, and weakly by the tensor fascia lata. And then the muscles for flexion are the hamstrings, semitendinosus, semimembranosus, long end of biceps, and the short end of biceps. And the medial rotation by semitendinosus and semimembranosus, and also you can say poplitis when there is a non-bending knee joint is extended. And lateral rotation, of course, is by the biceps femoris when knee is flexed. So this is the point. And the factors limiting the movement, so checking the movement, like this extension would be checked by anterior edge of the lateral meniscus, and all these things, and the anterior cruciate ligament. And this flexion would be checked by calf or leg contact thigh, or the length of the hamstring. It's also a factor. More knee flexion is possible when hip joint is flexed. So cannot flex cannot fully flex knee when hip is extended. So these are the things, and of course the medial and the lateral ligaments, their factors I've already told you that the medial rotation is prevented by collateral ligaments. So this is and the lateral rotation is prevented by collateral ligaments, which become taut, and the anterior cruciate ligament becomes found around posterior cruciate ligament. So these were the factors and of these movements, right? So this is been a general discussion of the muscles producing movements. I just wanted to recapitulate many of the things. We're moving quickly to the innervation of the joint. Very simple. So as a Hilton law, this nerve supplying these muscles anteriorly and acting involved in movement, flexion, extension. They also supply the muscles and the joint. The muscles which across the joint supply, their nerve supply also supplies a knee joint. This is the Hilton law. So the articular branches from the femoral which branches the west side, tibial and common peroneal, the common fibular nerve. They supply the anterior posterior lateral aspects. Obturator and saphenous also supply articular branches to its medial side. Let's see. So this is, this is the femoral nerve, right? Right, femoral nerve. It's coming, its branches supply it. And then you see coming down, you also see this is the saphenous nerve, gives branches to that as well. This you can see and identify over here, right? And this is femoral nerve branches. And you move down, and here what you find is this saphenous nerve branches. That's what you do. And this is the third nerve side, medial side. This is the obturator nerve, right? And as you move on, this was the nerves giving branches from above, and as we come at this point, we have the common peroneal nerve giving branches to it, and then the tibial nerve, right? These are the two nerves, common peroneal on the lateral side and the medial on the medial side. This is tibial nerve, which various branches to the knee joint. So lastly, the Bursae. There are about 12 to 13 Bursae around the knee joint, and the main are told in the next table, the next slide. Not the table, actually, it's just a list. So this could see various Bursae. I told you one Bursa, this is suprapatellar Bursa, right? And then say gastrocnemius has a Bursa, right? The popliteus has a Bursa. And we move on. These are the classification type major Bursae: suprapatellar and prepatellar, subcutaneous, infrapatellar, deep infrapatellar, popliteus, and serine bursa between the pes and serinus and tibia and tibial ligament, subtendinous and semimembranosus bursa present relative to the names. I told you the suprapatellar quadriceps femur, prepatellar between skin and patella. Prepatellar is present between skin and the patella. Subcutaneous infrapatellar between skin and tibia. Very important diseases like suprapatellar and infrapatellar. The clergyman will tell in the next section. It's already getting too long. So deep infrapatellar between patellar ligament and tibia, and popliteus. I told you popliteus bursa, popliteus tendon and the lateral tibial condyle. And then serine bursa, show you the picture, subtendinous and semimembranosus bursa. This is prepatellar and infrapatellar bursa. And then is a suprapatellar. I've told you already the names. So you see one by one, this is the subcutaneous prepatellar bursa, right? This is shown here, this over here, subcutaneous prepatellar bursa. This is the, right? And at this picture, this is the suprapatellar. This is the suprapatellar bursa, subcutaneous. And thus then some of the bursae over here, bursa and the plural bursae, and you could see over here, that's this is, this is the various, like this is the popliteus tendon has a bursa, and semimembranosus also has it. Then move on. This is the suprapatellar bursa, again in this position, and I told you already various bursa. And the last I tell you, this is the pes and serinus, the three muscle tendons, gracilis, semitendinosus, and sartorius. STS, sartorius, gracilis, and semitendinosus. These are the guy ropes to show you. These are the three muscles, and they are inserted over here. Three, like goose foot, and they are inserted on like this. They have a very big bursa because these are three very important tendon movement continuously. Of course, bursa are present to prevent friction and to prevent damage to the muscle tendons. A lot of movements occurring at the knee joint. So these are the last bursa, pes and serinus, and this is three muscles comprise that, and a bursa, a large bursa is present in this part of the body. And this is again, lastly, again the suprapatellar bursa. You already know this is the suprapatellar bursa. I thank you very much for your patience listening to me. I will try to deliver and cover everything about the knee joint, and accept its, of course, diseases and its applied anatomy. We'll discuss later. Thank you very much. Stay tuned and subscribe my channel, like the learning anatomy, and lots of care, lots of care.